Good evening, everyone. It is my absolute pleasure to welcome you all to this quarterly meeting of the Hair Research Society of India. This platform brings together a distinguished gathering of professionals and experts in the field of dermatology and trichology, and we are thrilled to have you here. Today's program promises to be both insightful and enlightening, with the renowned speakers sharing their knowledge on topics ranging from scalp mysteries to clinical hair disorders. We are particularly honored to have Dr. Devakar Yesudian from the UK joining us today, along with our esteemed local expert Dr. S Murugusundram, whose remarkable contributions continue to shape the field of trichology. As the founder of the Chennai Skin Foundation and the Yesudian Dermato-pathology Laboratory, and the chief editor of the Indian Journal of Trichology, Dr. Murugusundram has been instrumental in advancing research and education in hair science across India. His dedication, vision, and expertise have elevated our understanding of hair disorders and fastened innovation in clinical care. We owe him deep gratitude for his ongoing leadership and mentorship in the field. I would also like to take a moment to acknowledge our mentor and teacher, Professor Patrick Yesudian. His invaluable guidance and profound contributions to dermatology and hair research have inspired generations of professionals, including many of us here today. We are deeply grateful for his leadership and the role he continues to play in shaping the future of this field. As we delve into the complexities of hair research, I am reminded of the beautiful wisdom in Thirukkural 964, which says, Talayin irinda Mayranayar, Mandar Nilayin irinda Kadai. When a once highly respected person falls from their position, they are considered as insignificant as fallen hair. This Kural reminds us of how something as simple as hair holds unique significance, symbolizing not only beauty, but also the deeper complexities that we aim to understand through our research. I am also reminded of the Bible verse Matthew 10:30, which says, and even the very hairs of your head are all numbered. This reflects the value of every detail of our being, reminding us how even the smallest aspects of our work, like the very hairs we study, carry great importance. Finally, a special thanks to Dr. Reddys Laboratories for their generous academic support. Their commitment to advancing medical knowledge and research has been invaluable, and their contributions help make gatherings like this possible. Let's make this most of this evening as we explore the fascinating world of hair research, learn from one another, and continue to push the boundaries of dermatology and trichology. Thank you, and let's begin. Dr. Devakar, please.
Hello. Vakadla.
Red light over the parali. Okay, okay, sir. Yes,
This pointer.
Laser pointer.
It's okay. Good evening, everyone. Thank you for the Hair Research Society of India, particularly Murugusundram, for organizing this. And thank you also to all the sponsors, particularly Dr. Reddys. Today I'll be talking about a condition which I think we see fairly uncommonly. I've given it a cryptic title, Unraveling Scalp Mysteries. I'll divide the talk into three parts. Slide or move. He'll change. Next slide. I'll divide my talk into three parts. We'll look at the case report first. We'll discuss about the condition, and then most importantly, we'll see how to treat this condition. Next slide. So this patient came to me about 2 or 3 years ago, 28-year-old gentleman. He's from Poland. He had a sore scalp of about 12 months duration. He said it keeps bleeding on occasions. He also has boils on his chest. And initially it didn't bother him too much. But in the last 6 months it had worsened. And because it was very symptomatic, he came to me for more treatment. There was no relevant past medical history. The only thing is that he smokes about 15 to 20 cigarettes a day. The GP was quite good. He had given him limycycline. Limycycline is a tetracycline. This is the one we use most often in the UK. So I guess it's similar to doxycycline, which you use here. This was the picture. You can clearly see that there are nodules. Some of them are fluctuant, and some of them, when you touch them, there was a bit of pus discharge. Most of them are not tender, but some of them were quite tender. And this was his chest. You can clearly see that there are some pustules and a couple of early nodules coming up on the chest as well. So I'm sure you would have made the diagnosis. It's dissecting cellulitis with acne. And it's a combination that we see fairly often. Because the GP had already given limycycline, I wanted to give him something a lot stronger. So this is a combination that we use for hidradenitis. Now we think that dissecting cellulitis is similar to hidradenitis, and we'll do that in the discussion. So I treated it as though it was hidradenitis, gave him clindamycin and rifampicin for 8 weeks, and he was delighted with the response. He said it was 80% better within 6 to 8 weeks when I saw him, and he had absolutely no side effects. And this was him after just 6 to 8 weeks. You can clearly see that most of those fluctuant nodules had gone. There were still 1 or 2 left behind. And you can see at the bottom that there are some comedones still visible. So you can see that there is an improvement. Some residual activity was still there. So what I said was, let's go on to the chronic phase. So I gave him isotretinoin, 20 milligrams a day, quite a small dose. And on this occasion, the second occasion, I told him, oh, why don't you think about stopping smoking? One thing I've learned about psychology in patients is that if you tell them the very first appointment, oh, stop smoking, lose weight, they don't usually take heed of you. But once you've sorted out their skin problem and they know that you are trying to help them, at that point, if they come back to you and you say, listen, I think you really have to stop smoking, you have to lose weight, then they listen better to you. So I always make it a point in the second visit to bring up all these most sensitive topics, and I think it does work. This chap didn't attend for follow-up, but I did call him about 2 months later, and he said he was clear. I don't know what that means, but obviously no new lesions, and therefore I think there's quite a good result on a very low dose of retinoid. I'm sure you will agree that this is a significant response. So within 8 weeks, you can see most of the hair loss is decreased, most of the activity is reduced, and that residual activity also seems to have improved with the use of low-dose isotretinoin. Now I'm going to talk a little bit about dissecting cellulitis of the scalp. And it's got this wonderful Latin name, perifolliculitis capitis abscedens esophoidians. So if you break it down, it's a very, very literal translation. Perifolliculitis means it's around the hair follicles. Capitis because it's on the scalp. Abscedens means there is either discharge or withdrawal. Esophoidans means it's suffocating the hair follicles. So if you know what each means, actually, you've already got the pathogenesis of the condition right. So excellent use of nomenclature for this particular condition. We know it's a chronic inflammatory condition. It's part of the follicular occlusion tetrad. So that's why this person had acne. They are more likely to get hidradenitis suppurativa, and sometimes they have pilonidal sinus as well. So you know about the triad, and this is a tetrad if you have dissecting cellulitis as well. And the most common clinical manifestations are these abscess and nodules, very similar to what I've seen, but they can sometimes go on to sinuses and scarring. So very much like hidradenitis, if you don't catch it early and it goes into sinuses and scarring, you've lost that opportunity. It becomes a permanent scarring condition, and that's a lot more difficult to treat. So we'll look at that in the pathogenesis and also in the treatment for this condition. It's relatively uncommon. It's only about 2 to 3% of all hair disorders in a hair clinic. But you will see that it's more common in those with darker skin, particularly Afro-Caribbeans. It's more common. And it's usually younger adult males, usually 20 to 40 years. So there seems to be a hormonal component, maybe some androgen sensitivity is there. And as we've already discussed in my patient, there is an association with smoking, very much like hidradenitis suppurativa. What is the pathogenesis? We think it's because of follicular keratinization, dyskeratinization. So there's something going on in the follicle, some defect, which makes you retain more keratin, and therefore the follicles get clogged. And these points are exactly the same as what happens in hidradenitis. So there's accumulation of debris in the hair follicles, it becomes ballooned, it ruptures at the base, and it releases all these material into the dermis, and there's secondary bacterial infection. That's why you get all this pus discharge. And I was talking to Krishnakumar before the meeting, and the skin microbiome is probably quite important here. Just like in hidradenitis, there are these very specific bacteria which cause the manifestations of hidradenitis. So I suspect there will be a similar predisposition. Maybe there is something in the microbiome in these people who make them more susceptible to follicular occlusion and the secondary bacterial infection. Let's go on into more detail into the clinical features. So there are these suppurative nodules. They are tender, they do discharge. And then you get the sinuses. The way you know it's a sinus is if you press one area which is 2 or 3 centimeters away, the other area will discharge pus. So we know that both these nodules are actually interconnected through a sinus under the skin. And there's usually reversibly hair loss in the beginning, just like in my patient, you saw all the hairs regrowing. But if you don't treat early, it becomes permanent. And as you will see from some of the slides later on in the management, you may lose all your hair if you're not careful and you don't treat it early enough. And sometimes it can look like acne keloidalis. It can look very hypertrophic, and there can be keloidal scarring as well. What are the associations? We've already talked about follicular occlusion, so the other conditions like hidradenitis, but you can also get a seronegative arthritis with it. And that can manifest because of the neutrophilic increase in the sensitivity of the neutrophils. So seronegative arthritis is quite common. So we probably need to ask our patients, do they have an arthritis? Very rarely you get keratitis as well. And then you have these neutrophilic syndrome, Sappho and Kidd syndrome, where you have increased sensitivity of the neutrophils, and therefore that's an association with this as well. There are certain dermoscopic features as well. I'm sure you all use the dermatoscope for some of our skin conditions, and this is one condition where it may be helpful. Let's look at each stage. This is the early stage, and you can see that it looks fairly similar to alopecia areata. A shows black dots, B shows maybe a little bit of yellow dots, and C shows broken hairs. So this is the first stage. This is the first stage in which you get these fluctuant nodules, and this is still reversible because it looks like alopecia areata in the trichology. This is the second phase where you can get abscedence, which means it's starting to discharge. So these are featureless yellowish areas, and then you can see these areas of scarring starting to come up. Again, some broken hairs, but this is the next stage after the first stage. And then the final stage is, this is where you get the sinuses. And you can see that there is loss of follicular openings here, so it's become scarred. And you can see multiple hairs coming from each one of these. These may even be small sinuses. So this is the next stage or the final stage of dissecting cellulitis. And there is a classification now for how to stage dissecting cellulitis. In stage 1, there's only these isolated nodules and abscesses, and there's normal skin in between. So that's why when you treat it, it becomes almost normalized. Then you get stage 2, where you have intercommunicating sinus tracts, but still no scarring. And then the stage 3 is when these nodules occur with scarring and there is permanent alopecia. And by this time, it's probably too late for medical treatment alone to work. And these are the 3 stages. Stage 1, where you get the fluctuant nodules. Stage 2, where you start getting the sinuses. And stage 3, where you get permanent scarring alopecia. This is from a German journal which came about 5-6 years ago. There are other conditions which can mimic it. So we'll just go through a few conditions which can look very similar to dissecting cellulitis, but you have to be cautious that we don't miss them. This came in the British Journal a few years ago. This chap had never had any skin problems before. He had no acne when he was younger. He was in his 30s. And then suddenly, over a period of 6 to 8 weeks, he developed these intensely fluctuant, boggy nodules over most of the scalp. And it looked just like dissecting cellulitis, and it probably was. But the difference here is this chap had just started taking anabolic steroids. So it was the anabolic steroids which made him tip him over to get dissecting cellulitis. So anybody with a short history of these fluctuant nodules always ask for a history of whether they are taking any drugs for bodybuilding. This is another patient in their 30s, had a history of peptic ulcer disease for which they had had surgery 10 years earlier, had always had a few bowel problems, and then over a period of 2 years had this fluctuating nodules with discharging sinuses on the scalp, tried every antibiotic under the planet, but nothing seems to work. And then finally, they did a colonoscopy and saw pseudopolyps, and you can see some ulceration. And in the crypts, you can see these non-specific inflammatory infiltrates. So this was Crohn's disease, presenting as though it was dissecting cellulitis. This is a condition which we look for in any scarring entity. So this person has had dissecting cellulitis for many years and then suddenly developed this massive lesion within it, and this was a squamous cell carcinoma occurring within an area of dissecting cellulitis scarring. Now this patient I saw just on Monday actually. He came with this on the scalp, and that is a closer view. You can see it's quite well settled now, but mother showed me some pictures on her phone where it was very boggy. So these things were quite boggy nodules. Now this is a condition which we see uncommonly, and I came across this only this year. So this is a condition called alopecic and aseptic nodules of the scalp. So it's a condition which was first described in 1992 as a pseudocyst of the scalp, mostly in young people. And we think it's because of follicular occlusion or a deeper folliculitis with immune reaction causing a granular matrix change, but we are still uncertain. But some authors feel that it's a form first of dissecting cellulitis of the scalp. And it's usually asymptomatic, but you get these dome-shaped nodules, sometimes with alopecia, but if you treat them, that makes that alopecia settle down. The histology is very variable. You can get non-specific inflammatory infiltrate, sometimes granulomas in the deep dermis, but sometimes you can get no specific histology at all. And it can resolve spontaneously. And sometimes if they are filling up with these pus, you can puncture them from time to time. But the treatment of choice is doxycycline, 100 milligrams a day for 3 months. And that's what we've started in our patient. And intralesional steroids have also known to be helpful. The authors in the AAD presented this patient where they gave indomethacin 3%. So an NSAID, when you give an NSAID topically, that can sometimes cause remission of these aseptic nodules in the scalp. Let's go on to dissecting cellulitis treatment. So this is what we want to know. How are we going to treat our patients? And you can divide it into 4 parts, either topical or systemic antibiotics, and then biological and procedural. Topical antibiotics is what we start with mostly. Topical clindamycin is usually used. We have a combination of isotretinoin with clindamycin in the UK which we use. Topical resorcinol, 15%, has also been known to be helpful. We don't get that in the UK, but I don't know whether you get it here. And then topical diclofenac gel, 3%. That seems to be quite effective. And there's a case report which I'm going to show you. This is the one. So this is a patient who was treated only with 3% diclofenac gel. And you can see an excellent response. They think it's because it has anti-inflammatory action. It's non-steroidal anti-inflammatory, so it inhibits the cyclooxygenase pathway, and that's the reason why you get remission of dissecting cellulitis, because we know that there's an inflammatory pathway here as well. You can use oral antibiotics as well, or oral retinoids, both of which we've used in our patient. You can use either tetracyclines, azithromycin, which is 3 times a week, ciprofloxacin, or you can treat it as though it's hidradenitis with rifampicin and clindamycin. Now, doxycycline is probably what we need to use most often, and we'll look at it a little bit more in detail. You use 100 milligrams. You can start off with once a day if you want, then make it twice a day. And then once you've controlled it for about 3 or 4 months, you can then use sub-therapeutic doses. You can use 30 milligrams, 40 milligrams, 50 milligrams, or half the tablets, and that may be enough for long-term use. Its anti-inflammatory action may be sufficient to control it. If they don't respond to doxycycline, you can use minocycline as well. This is actually a patient who was treated on clarithromycin. So again, clarithromycin over a period of just 6 to 8 weeks, and you can see excellent remission of the inflammatory changes. Retinoids are also very helpful. It decreases follicular occlusion, and there's an excellent response rate. You can see a 90% response rate. Other retinoids, alitretinoin and acitretin, may also be beneficial. Isotretinoin is the most commonly used drug, and the two mechanisms are, we've already know that it's anti-inflammatory, but it also reduces follicular keratinization. That's why it's so helpful for acne. And the dose, you don't need to use very high doses. 0.5 milligram per kg per day is enough, but some people use it up to 1 milligram per kg per day. The important thing is to assess after 3 months. If it doesn't work at all, even on the high doses, it's probably not going to work. You might as well change. But if it does work, you can use a lower dose as maintenance for a bit longer. This came in the British Journal of Dermatology, and you can see that even what looks like extensive areas of scarring have partially regrown with the use of isotretinoin. This is actually a patient who had KID syndrome who was treated with alitretinoin. So alitretinoin also in a dose of 10 to 30 milligrams a day may be beneficial for dissecting cellulitis. Quite a few biologics, but it's mainly the tumor necrosis factor inhibitors. Adalimumab and infliximab are the commonest drugs. There are recent reports of IL-17 and 23 blockers also playing a part in this condition. In adalimumab, you give the higher dose. You give it every week rather than every other week. So much higher dose, and you give a loading dose as well. So you use the HS regimen. Some people have used lower doses if they've partially controlled it with the higher doses. So you bring it under remission with the higher dose, then use the lower dose to control it. And this is a case report where adalimumab was used. And again, you can see excellent regrowth of hair, almost complete clearance except for 1 or 2 areas in the scalp. JAK inhibitors, you can never write them off now. They're used for every condition you can think of. There are case reports, and they seem to be very helpful for HS in some areas because of its anti-inflammatory effect. This was the gentleman who had upadacitinib. You can see how severe it was, and you would say, because this person had tried everything, including adalimumab, it didn't work. And then when they gave him upadacitinib, it seems to have worked really well. There are miscellaneous drugs as well. Prednisolone, you can give 5 to 10 milligrams a day along with the other drugs. That seems to have a good anti-inflammatory action. Finasteride, 1 to 2 milligrams a day, a very low dose. Zinc, anywhere between 50 to 150 milligrams a day. Zinc seems to be useful for all these follicular keratinization conditions. I use it for acne and for hidradenitis as well. So it is something which is quite safe. I ask patients to buy it themselves over the counter. And finally, apremilast seems to be a reasonable option if all the others have failed. This is a patient who had apremilast. Again, this patient had had numerous other treatments. Nothing worked. And when they gave apremilast, there was excellent remission of the condition. Finally, the interventional treatments. So if none of the medical treatment works, what do we do next? PDT seems to work quite well because it sort of kills off the biofilm. The laser treatment also helpful. And finally, radiation and surgery. And we'll look at each one of them. So PDT, as I said, it sometimes destroys these microbial biofilms. And look at the response rate, 88%. There were only 6 series available in the literature, but of those 6 series, 88% of them did quite well for the condition. You can get hyperkeratinization in this condition with inflammation, and this ablates all that. So it's a physical ablative way of getting rid of it. Lasers works by destroying the hair follicle. So if there's no hair follicle, then there's no inflammation. But the only thing is, it causes scarring, and then the hair doesn't regrow again. So it's probably the last stage. If none of your medical treatment works, that's when you use it. And you can use ND-YAG, that's the one which decreases inflammation, but long pulse ruby laser is also used for removing hairs. And this is a patient who had ND-LAG. You can see quite a good response to the treatment. I wouldn't say it's perfect, but you can see that when there's nothing else which works, you have these interventional treatments which sometimes pays dividends. Radiation, electron beam therapy and brachytherapy, but again very aggressive and destructive forms of treatment which may be helpful. Finally, intralesional steroids, you use it for symptomatic relief. The only thing is, this doesn't actually change the disease progression. It can calm down the inflammation, it can decrease the nodules a bit, but the medical treatment is required to switch off the condition. You have to use, all the first few drugs we mentioned, the antibiotics, the retinoids, and this is only to calm down any inflammation or discharge in the end. You may need to use higher concentration if there's lots of scarring to soften the scarring as well. Excision, you can excise all the affected areas. In fact, some excision involves the entire scalp, and it has to be done really by plastic surgeons, I think. But you have to use it only when the inflammation is under control. If it's still active, you can actually aggravate the condition further. And this is a patient who had had very, very extensive dissecting cellulitis. You can see it's almost like the cutis verticis gyrata picture, but this is all scarring. They had to remove the scalp completely and then graft it, and you can see there's no hair follicle, but there's no disease either. So that's very, very drastic when nothing else works. Let's look at the flow chart as to how to treat it. So if it's mild disease, use topical antibiotics, topical clindamycin, and then go to doxycycline 100 milligrams once or twice a day. Or if that doesn't work, go to retinoids. That's exactly what we've done, but we've used clindamycin and clindamycin and rifampicin because the tetracyclines didn't work. Some people use acitretin as well. If you want to use procedural, then you can use intralesional triamcinolone or consider photodynamic therapy. So this is for mild disease. If it's severe, it becomes a bit different. So again, you use the same thing, doxycycline or rifampicin and clindamycin or the retinoids. But then after that, you go to adalimumab. Remember, I told you it's the HS dose, so 40 or 80 milligrams weekly, and then you start decreasing the dose once you've got it under control. And infliximab is even more potent than adalimumab, but it's very hard. You have to give it as an infusion. And then finally, if none of them work, then you use the IL-17 or 23 inhibitors. If you want to do procedural things, then intralesional triamcinolone, you can try excising it, photodynamic therapy, and then finally laser therapy. So in conclusion, it's a condition associated with follicular occlusion. You can see there are numerous treatments available for it, but remember always these other conditions which can occur as mimickers. Always make sure you don't miss out on those other conditions because they can also be very important. Thank you.
I just wanted to mention Devakar, Professor Tambia's famous quote surface, the perifolliculitis, capitis, obsidians, extraploidians. He enjoys telling it as a, right. I think it is from Ormsby Montgomery, that too, that how he tells all this long. So whenever this dissecting cellulitis scalp comes, he will just enjoy telling this full thing. That is why we remember it so nicely even at this age, because he was repeatedly telling it. Perifolliculitis capitis, perifolliculitis capitis absidians et saphoidians. I mean, if time permits, couple of words. I have an 82-year-old lady. Even day before yesterday she came. And really depressing to see whenever she enters my room with her son. I am treating her for the past 8 years. Just like the photograph you showed, I have tried doxycycline, but very difficult because pus is pouring. Delacin, say, of course, clindamycin, of course, I never gave delacin with rifampicin because she cannot tolerate, because she already 82. I am seeing her from the time she is 70-year-old. Isotretinoin also I tried. Ultimately, I asked the plastic surgeon whether he can help. Actually, plastic surgeon is very much afraid to touch her because of her age. And as you rightly said, still pus is pouring. So I just requested him, at least do a debris and give her some relief. When she comes and cries, it is really miserable to see. Something you do for that too from a lower middle class person. So we just want to help them. That's why when you said, I really appreciated. We have to catch it very early and treat it very early. Otherwise, no, any number of doxycycline, isotretinoin, she just responded, but again it went off. So to catch them very early is a good option. But by the time she came, the pictures you showed, it was so. I was just wondering whether I can get any clue from your speech to help that lady. But with the pus pouring, even for a plastic surgeon, you rightly said, no, it may make things worse. So it is really a miserable condition. When you see how they are suffering, that you understand the difficulty of the people. When day before yesterday, when she enters, I feel desperate. Sir used to say, some of these dermatological conditions, they are orphans. He would say that famous Shelley's words. I wanted to share my experience. No, she is too old for biologic and they can't afford also biologic. So, question does... 10 milligrams of pred I didn't try. Probably next time as you say along. And doxycycline I have given, Jack I haven't tried because she's 84. We have to do older people all this TB workup and all to do it. It is a bit tough. And doxycycline and minocycline quite a lot I gave. Limey I gave, but somehow Devakar, Limey is not so popular in India. So I don't know why. Even I took it up initially. Mino works better than Limey for us. What do you say? Anyhow, it was a very good talk. I really enjoyed.
Thank you. Yeah. Next talk.
Dr. Devakar can go to the next talk, son.
Okay, let's go.
What I thought I'll do is tell you about 5 unusual facts about hairs which I learned. What I'd suggest is that you just note down the answers for yourself and see how many you get correct out of 5. The first question is, do blondes have more hair than people with other hair colors? For example, do they have more hair than those who have black hair and those who have more hair than red hair? And the answer is yes, they do have more hairs than those with dark hair. We have 5 million hair follicles in our body, and only 2% of them are on the scalp. And the density is very variable depending on the color of the hair. Blonde hair have about 150,000 hair follicles. Those with darker hair have about 100,000 hair follicles. The only thing is, their hair is finer. And there is lots of debate as to why those with lighter hair have more hair follicles. And one explanation may be evolution. After humans were first found in Africa and they went to more northern latitudes, they started losing their color of their skin. And they lost the color of their hair as well. But the problem is the sun was still there in the summers, particularly in the northern and southern hemispheres. So as an evolutionary defense, instead of having darker hair, it became more in density. So as soon as more density occurs, it gave partial protection for the hair. That's the reason why blonde hairs are more dense than black hairs. It's actually a recessive gene. Only 2% of those who are in the world have blonde hair. And the reason they have this finer color is because they have less of eumelanin. And another interesting fact which I found out was that those with blonde hair, sometimes it gets darker with age. When they become teenagers, with hormonal influences, the hair actually becomes darker. So that's the reason why you have to be, it's an unusual fact which I learned when I was researching this topic. Next question is, can hair taste or smell? Do they have receptors which taste or smell? Yeah, the answer is yes. We do have receptors which are actually taste receptors on the scalp. And various flavors can be detected, but they are mainly the bitter tastes. And again, there's an explanation for this. This is because early humans, when they were foraging through for food, there are lots of these poisonous substances. And one of the ways of detecting them even before you come close to them is your hair actually coming into touch with them and having these taste receptors. So you're not coming into touch with it, only your hair is. So it's an early warning system against potential dangers. Now you may think, oh, it's actually not a very relevant factor. But actually it is. Because they found that the taste receptors in the hair, this particular number, OR284, regulates the hair follicle growth. And there is actually a new agent, Sandalore, and that prolongs the active growth phase in vitro. They've published on this as well. So this came about 4 years ago, and it improves telogen effluvium associated parameters. So using these unique receptors, you can see that there is some scientific reason why we have to find it. They may actually help hair growth in the future. Next question. Is our scalp hair strong enough to support an elephant? Which means if you take all our hairs in the scalp, can it support an elephant? Yes. Okay, let's look at the facts. Each hair can support 100 grams, that's 2 candy bars, and we have 100 to 150,000, that comes up to 1,000 kilograms. So it can actually support 2 elephants. So it's a trick question. It's not 1 elephant, it's 2 elephants. And this such a fine thing can support so much because of its structure. It's due to the keratin, the way it's arranged in a helix shape. And this structure is very unique. It's almost like the DNA. You get these amino acids, they become proteins, and then they form tetramers, which become intermediate filaments, and they become microfilaments, and each one of them has a helix. And around this helix, which is already giving it strength, there is high sulfur content of matrix. All of this put together is what gives it so much of resilience. So this is the structure. And then you get the chemicals. You get the helix with the high proteins. You get the high tyrosinase. You get the high amount of sulfur around it, sulfide bonds. So that's the reason why it becomes so strong, and it's almost unbreakable at some point. So you can stretch them 40% before they start breaking, and the tensile strength is actually megapascals, 200 to 260 megapascal. It's almost as strong as steel. If you look at this weight on weight, it's actually as strong as steel. That's how hard your hair is. So again, I'm sure most of you would have got it wrong because you would have said one elephant, but it's two elephants. Now next, hair is the fastest growing tissue in our body. True or false? True? KK?
False. Statistically, that we false.
So what is the fastest tissue? Yes, it's the bone marrow. So bone marrow is the, again I put that to trick you. You'll say yes to everything. So bone marrow is the fastest growing tissue, but hair is the second fastest tissue. It grows by about 1.25 centimeters a month. So over a period of 6 months, it grows by about 6 inches. And it's a constant stage of growth, anagen, catagen, telogen. But why is it that hair is in different parts in different lengths? Why is our hair so long in the scalp and why is it short in the eyebrows? And that's because of the duration of the anagen. So each hair follicle in the scalp goes through about 10 to 30 cycles, and the anagen there lasts 2 to 8 years. But in the eyebrow, it only lasts 2 to 3 months, and there are much less cycles. So that's the reason why the length is different, and also the way it behaves in the long term is different. And finally, can hair grow after death? It can. Again, we'll have to define what death is. So death is not a single event. In fact, there's a very nice quote which I've written there. We are all born with a terminal disease called life. We all know we have to die. So we are all born with this terminal disease. And we think death as being just one instant where we think there's loss of brain activity, you lose your breath and you lose your heartbeat. But actually it's much more than that. You get these cellular changes and the biochemical activity decreases, and that takes many, many days. But what actually happens in the hair, it's actually a false growth. What happens is that the hair looks like it's growing because the skin dehydrates and retracts from these biochemical changes. And this exposes more of the hair shaft, and that's why it looks as though the hair grows more. It's an apparent growth in the hair. So I hope you liked all these unusual facts. Thank you.
Next, I'll give my talk on dermato-pathology.
So before KK sir starts, the ancient Tamils knew that the hair has got this smell, and there is a Sangam poetry in which the Pandyan king had a debate, and he wanted to know whether his wife had a natural flavor for the hair. And that was a big, I think it's very popular poem. Yes. The poem goes like this. He says, he calls all the beetles and he says, I think you are going to all the flowers. Have you ever smelt a flavor from my wife's hair? So it's like that. So probably they knew. So probably they knew that.
Good evening, all of you. I'll be talking on how does dermato-pathology help us in diagnosing scarring alopecias, and tell about few basics in horizontal sections and vertical sections. I always we salute our teacher who has motivated us, still motivating us to study. These are some terms. Whenever you take trichopathology, some terms, some structures are there. These are all horizontal sections of hair follicles. This is an anagen hair. This is a catagen hair. See that apoptotic cells. This is the telogen hair. See the trichlemal keratinization. These are vellus hair, and this is follicular miniaturization. These are very basics, because when you are going to study horizontal sections, the algorithm goes like this. Non-scarring alopecia, is there follicular miniaturization or no? Scarring alopecia, is there follicular miniaturization with inflammation or no inflammation? In that context, we have to know whether what is follicular miniaturization, what is vellus hair, what is telogen hair, what is the ratio. because we don't have data in Indian population. In horizontal section, you see a Caucasian race, an Australian Negro, we get around 24 to 25 hair follicle units, but we don't have such strong data from the Indian population. And most of the horizontal sections, reporting is possible when you take a 4 millimeter punch. Unfortunately, many times when I get biopsies of the scalp for alopecia diagnosis, they only give me a 3 millimeter punch. With a 3 millimeter punch, it is very difficult to quantify and talk about the ratio of pterygium hairs to the miniaturized hairs. This is a cartoon to show that this is the infundibulum, isthmus, bulb. And this is the bulge area, because this is very, very important where you see the inflammation. In inflammation in alopecia areata, you find more in the bulb. Inflammation in lichen planopilaris or discoid lupus erythematosus, we see more in the bulge area. Anything in the bulge area, there is going to be scarring and the hair follicles are not able to grow. This is a cartoon showing that if the bulge area is involved with inflammatory cells, there is going to be a permanent alopecia. On the other hand, if it's like alopecia areata, you get it in the bulb. It is a reversible alopecia. So, coming to classification, there is a primary scarring alopecia and a secondary scarring alopecia. In primary scarring alopecia, we still further classify based on the inflammatory cells. It's a primary disease. This is very, very important from the histopathology point of view. As a morphologist, we look into the cells, whether they are lymphocytes, neutrophils or mixed cells. If you have lymphocytes, classically you have lichen planopilaris and discoid lupus. Neutrophils, we have folliculitis decalvans and dissecting cellulitis, which Dr. Devakar spoke about it. And mixed in acne choroiditis and all those things. Now coming to the secondary scarring alopecia, it's a combination of infections, trauma, tumors and radiation. So that is from the clinical aspects, whenever the dermatologist or trichologist is looking at alopecia, he has to know under which category it comes, so that it is easy when the pathologist sees the slides, he can dialogue with the dermatologist. The scarring alopecias has got patterns. There could be inflammation, pustules, abscess, or it could be just scarring where all the inflammation is gone away. So usually when we want to report on alopecia, we can do it on vertical sections or horizontal sections, but in certain situations, horizontal sections are very, very important, like androgenetic alopecia. So these are two methods, the Tyler technique and the Howard technique. We currently in my lab, we do this Howard technique so that we are able to get both horizontal sections. On the superficial portion of the epidermis layers, we make vertical sections. So that, why this vertical section? So that I can study the epidermodermal junction, comment on interface patterns, basal cell damage or basement membrane thickening. The horizontal sections help us to count the hair follicle units, comment on sebaceous glands, comment on follicular miniaturization. This we can do, but all these things is possible only if I get a 4 millimeter punch. This is not possible in a 3 millimeter punch. That is very, very clear. So each has got its own advantage and disadvantage. So this is to show in horizontal sections we take at different layers. This is at the level of the subcutaneous fat. This is still higher. You see the sebaceous gland. This is at hair follicle unit. You find hair follicles with sebaceous glands. In the subcutaneous fat layer, you find more of terminal hairs. Once again, horizontal sections help us to know these are the terminal anagen hairs. This is at the level of eccrine sweat glands. Here, to show you one alopecia, androgenetic alopecia, you find this follicle miniaturized hairs. So when we are able to see like this, we can tell, okay, this is miniaturized, but the sebaceous glands look very prominent. We see no inflammation. We can categorically tell this is female pattern alopecia or male pattern alopecia. In that way, the horizontal sections are very much useful. And also you want to know the terminal to vellus hair ratio. It is only possible in the horizontal sections. It is not possible in the vertical sections. Vertical sections provide advantage because they give a panoramic view. You look at epidermis, dermis and subcutaneous fat, you can comment on the parakeratosis. For example, there is a psoriasis with hair fall. Vertical sections are mandatory. You cannot report it on horizontal sections because you may miss the parakeratosis. For example, this is a view showing from the epidermis, dermis and deep dermis. You find there is infiltrate in the dermis, around the follicles, around the sweat glands. Looking at this pattern, you are looking at a lupus pattern. This is very easy to diagnose in a vertical section. Similarly, look at this. Even a first year will tell, looking at this, a lichenoid interface, this is a lichen planus. So vertical sections has got its own merits. So horizontal sections, it helps us to do the follicular counting, to detect inflammation, and useful for diagnose stage of alopecias. Like you have an androgenetic alopecia, you want to know whether there is scarring in the androgenetic alopecia, horizontal sections are better. Like these are all the scarring, the follicular dropouts, the fibrotic bands, all these things is possible only in the horizontal sections. So let us take two classical examples. I find this is the most difficult in lymphocytic scarring alopecia is discoid lupus erythematosus and lichen planopilaris. In fact, a couple of years back I listened to one dermatologist from London talking. He says, whenever I see a scarring alopecia with lymphocytic infiltrate, he says I use the term autoimmune alopecia. I asked him why, sir? Because it is very difficult if they come in the early stage or late stage to tell whether it is lichen planopilaris or discoid lupus erythematosus. It's very difficult. So I use the term autoimmune alopecia and they have to investigate. So let us see why this is very challenging, diagnosing discoid lupus erythematosus and lichen planopilaris. So this is a paper I was surprised to see. Yes, people have made misdiagnosed lichen planopilaris and discoid lupus erythematosus. It is when it can happen to senior people. All of us younger dermatologists and dermatopathologists looking at histopathology can make mistakes. Like discoid lupus, you find interface dermatitis can be seen in daily, but it can also happen sometimes in lichen planopilaris. Basement membrane thickening, classical, but you can see mild thickening in lichen planopilaris. Dermal mucin. Interstitial mucin is seen in dermis. Here, perifollicular mucin with fibrosis seen in lichen planopilaris. If you are not very much attention to details, looking at mucin, we may not get excited until it is discoid lupus erythematosus. Follicular plugging is common here. Perivascular inflammation is seen in DLE and mild inflammation is seen in lichen planopilaris. Sometimes we see periaccurrent infiltrate even in lichen planopilaris. I used to wonder whether I am looking at a subset of something like lichen striatus. So this is very difficult. Then so the clinical presentation has got points, histopathology pictures of point. So let us see. See, for example, this is a discoid lupus erythematosus. You find vertical, this is a vertical sections, epidermis. You find only infiltrate is here. It's complete scarring. You don't find any hair follicles. And you find periaccurrent infiltrate. In the horizontal sections, you can see infiltrate, lymphocytic infiltrate like this. This, if we see sometimes, it is very difficult. If I get only a superficial section like this, I will tell scarring alopecia, reason not known. It is left to the dermatologist to further investigate, do an ANA, look at any other skin lesion to make a diagnosis. This is lichen planopilaris. You find this once again, you find perifollicular infiltrate, you don't find interface changes. In the previous case, you don't find much interface change. Usually when we read discoid lupus erythematosus, we talk of interface change, but we don't see an interface change. We see only perifollicular and periacrine. In lichen planopilaris, we are not seeing much here. We see perifollicular infiltrate is here. If we see like this, see this pigment incontinence. This pigment incontinence may suggest this could be lichen planopilaris, but we can see this pattern even in discoid lupus erythematosus. So very, very difficult to comment only on this and this. So how to go? If I see a periaccurrent infiltrate, Basement membrane thickening, I will confidently tell it is discoid lupus erythematosus. But basement membrane thickening takes 6 months. If biopsy is done within the first few months, we may not see the classical basement membrane thickening in histopathology, discoid lupus erythematosus. That time there is a dilemma whether it is a lichen planopilaris or discoid lupus erythematosus. Then frontal fibrosing alopecia. Frontal fibrosing alopecia, you get scarring here, hair loss, and histopathology will show you something like lichen planopilaris. Other types of alopecias, follicular decalvans, where you get inflammation, pus, scarring, and you can get Staphylococcus aureus is grown. And histopathology will show you broken hair follicles, naked hair follicles, ruptured, and you find a lot of cells, neutrophils, lymphocytes, and plasma cells. So this is you don't make a diagnosis. So this is neutrophilic infiltrate with mixed inflammation with the naked hair follicles. You can even get granulomas because the hair follicles are ruptured. Then dissecting cellulitis of scalp, which Dr. Devakar spoke very well. Here this is Dr. Murugu's case, multiple discharging, multiple swellings, boggy swellings. He had acne and etc. And the biopsy shows epidermis. You find dense inflammatory cell. What I understand is, even though it is scarring alopecia, the sebaceous glands are very much intact till the late stages in dissecting cellulitis of scalp. That's very characteristic of this entity. These are all the granulomatous inflammation, higher power. Once again, you find multinucleated giant cells, lymphocytes, and plasma cells. Once again, sebaceous glands are quite intact, and you find the giant cells and lymphocytes here, multinucleated cells. So next is another scarring alopecia. This entity is that pseudoplate of Brock, where we are not able to tell the reason. We don't see inflammation, we see only scarring. There are no hair follicles, there are no sebaceous glands. It's end stage scarring alopecia. It is difficult to find the cause from the histopathology point of view. Then another entity is erosive pustular dermatosis of scalp, where you find erosion, crust, hair loss. Triggering factor is sun damage or acne keratosis. It is non-infectious. You find a lot of mixed inflammatory cells, neutrophils, lymphocytes, and plasma cells. This I have not seen. I only last time I think Dr. Devakar presented a case of erosive pustular dermatosis of the scalp. So histopathology role, we to tell whether it is an inflammatory alopecia or non-inflammatory alopecia. What about the fibrosis and the pattern of inflammation? And we tell them whether this alopecia has got scarring, will it respond to therapy or not, we can tell. See, this case is from Royapata Hospital. Lady having a scarring alopecia with pigmentation. Biopsy was sent. You find classical hypodermal hyperplasia with a lichenoid interface change with lymphocytic infiltrate. You find this apoptotic bodies and pigment incontinence. This is lichen planus causing scarring alopecia. Then this lady is from Texas. She has this sort of a hair loss looking like female pattern alopecia, and these histopathology images were sent to me for an opinion, and this is horizontal sections. You find sebaceous glands are intact. You find this is follicular miniaturization is there. What is interesting is you find this fibrosis. This fibrosis is there. In these areas, the sebaceous glands are not there, they are atrophied. So this is once again follicular miniaturization. Lot of follicular miniaturization is there, and also we see there is atrophy of the sebaceous glands. So what I told is there is female pattern alopecia, but there is a mild scarring. So usually when they get mild scarring in female pattern alopecia, maybe she has applied some irritant, but the response may not be great compared to a female pattern alopecia with no scarring. That's what I sent the report to them. This is another interesting case. I happen to see only one case from Tamira. This is from the journal. So they showed something looking like a female pattern alopecia, but trichoscopy, you see this trichoscopy pattern, and biopsy you find this sort of perifollicular fibrosis with inflammatory cells. This is fibrosing alopecia in a pattern distribution. So this can mimic a female pattern alopecia, but biopsy will help us to diagnose this fibrosing alopecia in a pattern distribution. This is the answer for this. This is from the JAD issues. See this pattern distribution hair loss. These are the variability in hair shaft diameters, peripellar cast, and this fibrosis, inflammatory cells. So this has got a combination of lichenoid inflammation, scarring alopecia, and follicle miniaturization. So this is the histopathology features of it. So histopathology plays a critical role in diagnosing of scarring alopecia. We can prognosticate if you what you think as a female pattern alopecia or male pattern alopecia, will it respond to treatment? If there is scarring, it is not going to respond. What you think as a female pattern alopecia may be pattern alopecia with scarring. In that way, we have a role, and both vertical and horizontal sections are important. I usually recommend to get 2 samples. Usually for scalp biopsies, 2 samples from adjacent areas are needed, and don't take biopsies from the area where the scarring is there. Take from the border of the area so that you get some amount of normal area also for us to compare. Thanks a lot.
Thank you, sir. I want to add only 2 points here. When you combine trichoscopy and then do the biopsy, then you hit at the target properly, because the trichoscopic marking for the biopsy site is very important. Then you don't miss the diagnosis. And regarding this fibrosis in female pattern hair loss, there is a difference in fibrosis. In the pattern alopecia, whether it is male pattern or female pattern, it is a loose fibrosis around the hair follicle, because there is always perifollicular fibrosis, because androgenetic alopecia is also considered as a early scarring alopecia. So there is a loose fibrosis which is not a proper scarring alopecia. But in primary or secondary scarring alopecias, there is a concentric tight fibrosis which really makes the hair follicle atrophic and leads to permanent alopecia.
One clarification from Dr. Murugusundram, like what is the site of biopsies you suggest for people who are listening? Like what area of biopsy in an alopecia you recommend, doctor?
So it's always better to do the trichoscopy and then choose the site. So without trichoscopy, if you do the biopsy, as you rightly said, if you do a biopsy without any hair follicles, completely scarred area, you may get a picture like pseudopelade of Brock. So you have to take a biopsy where there is a perifollicular plugging, or maybe some signs of, there is a trichoscopic signs of scarring alopecia. Then at that place, if you do the biopsy, then you may get good signs of histopathological evidence of scarring alopecia, so that you can compare trichoscopy, and with the aid of histopathology, you can make the precise diagnosis.
One more question, doctor. But why you have sent a lot of scalp biopsies of alopecia, but you never ask for horizontal sections? Why are you not asking for horizontal sections, doctor?
Because you have already told me, I think we have discussed about this. Horizontal sections are useful only for identifying the follicular miniaturization, only for androgenetic alopecia, whether it is female pattern hair loss or it is a pattern hair loss, and it is useful for when there is a diagnostic confusion, whether it is pattern hair loss or maybe diffuse alopecia areata or something like that. The horizontal sections do not give much information about scarring alopecia. So when it comes to scarring alopecia, we always do biopsies only for scarring alopecia. We don't waste the patient's money for pattern alopecia. So when we do scarring alopecia biopsies, the more information is obtained from the vertical sections than horizontal sections.
One question for Dr. Devakar. Can you share your experiences on your cases of scalp biopsies for alopecia or anything, doctor?
Yeah, usually we ask for horizontal and vertical sections in the UK, and then if you're not, if you're thinking of, things like lupus, we ask for immunofluorescence as well. But generally, it's quite hard to make a diagnosis because many of the site you have to take it is very important. Even I use a dermatoscope. I mark it and do it. But some people just take anything from the edge. But you have to see inflammation. Only then you'll get maximum information. But scalp biopsies are quite difficult to interpret if you pick out the wrong areas. So I agree with the point Murugs makes. But scarring alopecia, I don't know how frequent it is here. There we get the frontal fibrosing alopecia very commonly. And we don't biopsy it because we know that's what it is. Almost nothing else gives you that pattern. So it's almost a clinical diagnosis. So we don't do biopsies for them anymore.
It's becoming very common here also. The lonely hair sign I used to always show that. As you rightly said, you don't need to do a biopsy for frontal fibrosing alopecia. So it's obvious.
Thank you, Dr. Devakar. Sir, Chief, would like to tell a few comments, sir, on this?
Just a few points I made while I was listening to the speakers. I'm sure you all enjoyed it very much. There was a fantastic introduction by KK to the proceedings. Thank you for that. And as you rightly mentioned, we thank Reddys Lab, who have been with us throughout our growth of this hair society. We're very grateful to them. And then coming to Deva's talk about that condition, he has very nicely spoken about, exhaustively gone through the topic. It's an ancient disease. The first report was by Weiss and Parkhurst in 1920. They described it. And treatment-wise, I was surprised because there was a man called Druitt at that time, 1920s, who used to treat these cases with superficial X-rays, vaccine. In those days, for anything, staphylococcal vaccine was given because there are no antibiotics, no all infection, and 10% sulfur. The superficial X-rays, I found Deva's last point was desperate cases, we treat them with radiation, last resort. How the cycle has come a full turn. And the other thing is what Dr. Janaki mentioned about that nice musical term that was perifolliculitis, capitis, absidans, et xiphoidians. As Shelley says, it's marvelously mnemonic. And there's another condition which is now marvelously mnemonic is Curley's disease. Perifolliculitis, what is that? Perifolliculitis, not hyperkeratosis follicularis, et parafollicularis in cutum penin. So these are all called marvelously mnemonic. If you know the name, you know the pathogenesis of the particular condition. So some of these old books, and if you want a very good description of this particular entity, you will find it in Ormsby and Montgomery. As you said, the old is gold. Sometimes for good clinical descriptions, you've got to go back to these old textbooks. And when I left India in 1961 to go there, Dr. Tambaya said, you buy a copy of Ormsby, Montgomery and take it with you. Big book, I had to carry it with me because books were very expensive there. So I bought it here and then took it along. And I still have that book with all the underlines that I made, and periodically I go back to that book to find out about description of a particular disease. And one case report I must mention, as you have mentioned in the differential diagnosis of this boggy swelling. I remember one case when I was a house surgeon in Dundee. One little boy was going to the surgical side every now and then. The surgeon will take him to the theatre, incise the abscess, drain it and send him off. He will reaccumulate after some time. Finally, they took the trouble of referring it to the skin department, which was downstairs. And my chief there, Dr. Freen Bell, saw it. He said, it's a classical case of tinea capitis, Kirion. And we put him on a cruciofulvin had just come into the market. We started on that and the whole thing resolved. So it shows the importance of getting a dermatology consult at that time. And these few things about hair, which Deva mentioned, that was also interesting. And I believe in those days, the guillotine was found in the French Revolution. And they used to cut off the hairs of the women who were going into the guillotine. Your neck goes there, and the guillotine knife couldn't pass through the hair. So they had to cut the hair and then only chop the head off. So that is one of the things they used to do before women were sent to the guillotine. Cut the hair, otherwise the knife could not go through. And finally, KK's very interesting talk and it will be a very useful talk for all our PGs. I hope you'll once again give it in the college sometime. So thank all of you, not many, but as Tambaya would say, fewer the men, greater the share of honor. Thank you.
Reddys Lab for products. I request Dr. Reddys Lab to talk about some product.
Vote of thanks முடிச்சிட்டு
நீங்க பேசுறீங்களா சார்?
vote of thanks
நீங்க பேசணுமே உங்க டாக்.
நான் ஸ்கிப் பண்ணிடுறேன்.
நீங்க பேசுங்க.
Good evening. I would like to thank KK sir, who has been always with us and for chairing this session. And I would like to thank my friend Diva. So whenever he comes, he tries to educate us so much and such crystal clear, vivid clarity of thought and the way he explains. And you don't have to even take notes. It is always registered directly in your brain. Really honored and thanks Diva. And thanks to KK again for the excellent talk on scarring alopecia. And thanks to Janagi ma'am, my teacher, for taking time to come and honor us and share some thoughts with us. And again, my thanks to my teacher, mentor, Professor Patrick sir. Thank you, sir. And thanks to Reddys Lab for, as Chief said, for continuously supporting us without any hesitation. And thank you so much. Thank you, the technical support. Thanks to my friend Rajaram, who had been assisting me in coordinating with all the work. Thank you so much. Thanks to Julian for streaming this meetings in YouTube Live. Thanks once again. Yes. Diva, I would request Diva to honor Janaki ma'am with a bouquet. Thanks, Diva. I would again request Diva to honor his dad, not only dad but his teacher, Professor Patrick Yesudian. Thanks again, Diva. I would like to request Diva to again honor our good friend KK. KK has been a friend to Diva and myself for the past 30 years. Right from college days. Thanks, Diva. Thanks, KK. I would request YouTube cut பண்ணிடலாமா? cut பண்ணிடலாம்.